Hi everyone. We are so lucky and fortunate today to have with us very well-known specialist, a medical expert, Dr. Celeste van Drunick. She is a highly skilled obstetrician and gynecologist specializing in gynaecological oncology. Takes a while.
Yeah.
Yes, you obtained your obstetrics and gynecology qualification after 5 years of in-service training with completion of written and oral exams with distinction cum laude. Amazing. So your resume is outstanding and very detailed. So I'm going to hand over to you to give us a bit more about that, a bit of an introduction.
Yes, so after that I completed my obs and gynae, let's call it obs and gynae training, I then went on to do extra training, and it's a 2-year extra, also in service or practical, on the job training for gynecologic oncology, which focuses on the diagnosis, the investigation and the management of cancers of the reproductive tract. So any female cancer, not breast cancer specifically, that's more, general surgeons, but anything like ovary, cervical, uterine, vulva, all of these cancers are included, and even pre-cancers are included in this training. So I have a bit more surgical expertise in that area of removing the cancer, treating it, but also diagnosing it and then managing the follow-up after that.
Amazing. Very, very important work,
Yes,
I can imagine. Okay, so we're going to dive right in. I always stalk people a little bit before we chat to them. And on your IG, you talk a lot about women's health being underfunded, under-researched, and basically ignored, even by women themselves, which was very, very sort of eye-opening. And this is the driving force of our Wellness Hub, so it really touched home. Can you tell us more about this? And also in comparison, sort of, is this a global statement? It's most definitely a local statement. How bad is it? And what is happening to kind of change this and better it?
So when I actually looked at the stats again before this post, globally it's underfunded. Even in first world countries, the UK and the US also admit to it. Very low percentage of their funding is going to female research, and specifically reproductive research. And up until the 90s, I know that they've even excluded women, in certain research because of the hormonal complexity. It is picking up in first world, fortunately, but it's still not where it should be. In South Africa, it's definitely very underfunded still. Although we're trying to increase research and funding for research in South Africa, it is still difficult. There's ongoing budget cuts in South Africa, and the aid that was now stopped to South Africa definitely influences women's health in South Africa with regards to HIV/AIDS, maternal health, pregnancy health, and gynecological reproductive health. Yes.
I feel like that is almost it's a political problem in our country. I think women in general are very much the ones suffering the most, women and children. So that's very sad.
Yeah, so if we just talk about gynae problems, let's say more or less 1 in 10 women have endometriosis and 1 in 10 more or less have PCOS. But the funding for research is so disproportionate to that percentage, it's definitely not 10% funding that goes for research for that. All women eventually, if they live long enough, go through menopause, but it's definitely not that the research is in there for menopause. There is research, but it's not enough, fortunately so. And even cardiovascular disease is the leading killer in females' health, but most research on cardiovascular disease is done in men, unfortunately. So there's definitely a big gap there that we, should try and address if we can, or if we're in the research field.
Yes. Do you think anything is actually being done, or is it still it's still problematic, is basically what I'm saying?
It's definitely still problematic. People in the field are trying to increase the research, but there are many limitations to funding,
Yes.
especially in South Africa, and that's unfortunately, it might be political for different reasons. But that is unfortunately where we are. Yes.
That is so sad. Well, on that depressing note, we jump into ovarian cancer, which is no laughing matter. Okay, the silent killer. You mentioned on IG that symptoms are often very vague until it's too late, and to trust your gut, which I absolutely love, because I think a lot of us are so busy and so wrapped up in everyday life, we're not in tune with our bodies at all the way we should be. And I just wanted to chat a bit more about this because, the current stats and sort of how we can keep on top of this, if it is quite hard to pinpoint.
It is very hard. So unfortunately, most patients with ovarian cancer get diagnosed quite late into the disease because the symptoms are quite vague. But it makes it very difficult because when should you persist and react and be stressed about a cancer, and when is it just a urinary tract infection? It's very, very difficult. So what I'm trying to say with that statement, and also when I said it in that post that I made, is if you have certain symptoms, and I can go through them now, but let me go through them. So if it's persistent, right? So you've got this bloatedness, and you're already in your 30s, 40s, repeated urinary tract infections that has been treated a few times, but it's just not going away. The feeling that you want to go to the bathroom all the time, and you're really struggling suddenly with constipation, and now your tummy is distended, and you feeling full quickly. These are subtle things that could be any other, could be because of any other cause. But if they persist and they've been treated, but they're not going away, I want you to persist and saying, listen, my symptoms are still there. It's not going away. Yes, it's maybe something minor, but maybe it isn't. And so that's where the tricky part comes in. Some people give up and they just sit with the symptoms until it's very late in the disease. So trust your gut. If something is wrong with your body, get somebody else, or try again, go to the doctor again, or go to a different healthcare worker, and just try and say to them, listen, something's wrong. I think we need to investigate further if you haven't yet.
Okay, perfect. What are the stats? Do you know offhand?
So the thing is, that's also what makes it difficult about ovarian cancer. It's not a very common disease, luckily, for that reason. So it's about, the incidence is about 2 to 3 out of 100,000 people. So it's actually it's a rare, and it's the more rarer form of your reproductive or gynecological cancers. But as I said, if it comes on, it's quite serious, and it's difficult to screen for it. There's nothing proven that works to screen for it and pick it up early without symptoms. The medical field has tried ultrasounds, blood tests, combination of different things. Nothing is proven to decrease the incidence, how many people present with this. So that's what makes it so tricky. So really, if you have persistent symptoms, and especially these vague symptoms and a cluster of them, that's when I usually say, trust your gut, go look for a second opinion.
I actually read 2 or 3 days ago that they didn't specify which cancer, which was a little bit irritating, but they've come up with a blood test to diagnose cancer before needing all the other screenings and that. But I don't suppose it pertains to this because they didn't specify which cancer.
No. So I think what you're talking about, there is now research and evidence coming out where they can actually test for the DNA of certain cancer cells in your bloodstream, but that's still under research, and I don't know with regard which cancers they are,
which
actually
cancer?
looking.
Yes.
It's a bit different from cancer to cancer because each type of cancer might have different genetics. But it is quite interesting, and that is something that we might be able to use in the future. But it's definitely still under development phases, and it might take a year or two or more for that to really be practically implemented. Yes. But it's good.
It's great, but I'm sure we'll also be a bit behind in getting access to something like that. I'm sure the costs involved will be insane.
The costs might be initially, because it's sort of a DNA or genetic test that you do, it would be probably high initially. But I think as time goes on, usually the costs will go down as people start using it more. I mean, in South Africa, we do usually have access to most of the things that is, available in the world, but disproportionately so. So in the private sector more, and in certain places more, unfortunately. But we'll have to see what this brings. Yeah, it's
I was going to say, it depends which medical aid is going to cover that.
The public sector, that's something that's going to be very difficult to access. Yeah.
Okay, great. There's also a very interesting chat about HPV testing and pap smears, and I only know the difference because I had a scare a while ago. So I'm a few years ago, so I'm very familiar with the different what they're called, names for everything, but I can see why there would be confusion between the two. Can you break these down for us?
Yes, so I get this question a lot, and I like to explain it because this is definitely within my field. I also have, extra training in HPV disease with my gynecologic oncology training. So when we do a Pap smear, the old term is Papa Nicolau is the guy that developed this smear, and a smear is basically where you look at the cervix. We look at the cervix, which is the opening of your uterus. So if this is the uterus, that's your cervix, that opening, and that area. Okay, if I swab that and I look at those cells microscopically, I can see when they're starting to change and start to become abnormal or precancerous, and I can try and prevent cancer by doing that. So that's the one part of a Pap smear in today's terms, is looking at the cells, or cytology in medical terms. Okay, we still use that, but a newer test has now come alive, and that's the HPV testing, because newer research has now shown in the last few years, the last decade or so, that human papilloma virus is a virus that actually causes these cells that we've smeared for with the normal Pap smear or the old Pap smear test. That's the virus that causes the abnormalities. And now they've seen that it's actually even a better screening test than just looking at cells if you look at HPV, because it's even more specific and sensitive for looking for abnormalities on the cervix and for the cells. So people don't understand, but how does it work? How do you test? Is it two different tests? Yes, it's two different tests, but essentially you go to the gynae and it's one test. It's still a smear of the cervix, but where we send the specimen, we can then on that specimen request for cells or HPV or both, depending on what the doctor decides.
I read a really interesting stat that I think it pertains to the UK though, that 90% of people actually have HPV at some point in their life.
About 80% of people, even in South Africa, 80 to 90% of people in their lifetime sexually been active has been exposed to HPV. Right? Most people can clear it by themselves. It's a virus, so there's no antibiotic for it. It's only transmitted sexually. But most people get exposed. You can have sex with one partner and get HPV that just had it from somebody else, right? Because it's also completely asymptomatic. You usually don't have any symptoms. You don't even know you're carrying it, right? It doesn't cause a sore, a big discharge usually. Maybe sometimes cause mild symptoms, but very mild. Usually it's asymptomatic. And so 80 to 90% of people get it in their lifetime, but most of them clear it within a year, 2, 3 years, right? And about 20% of people don't clear it off of their cervix. And when it stays there and they don't clear it after, let's say, more than 3 years, that's when the HPV goes into the cells on the cervix and starts causing these abnormalities and precancers. And these are the people that we want to pick up to see, they're not clearing this HPV. We're worried because we know in 99% of cervical cancer cases, it's caused by HPV. And so we want to make sure that either they clear it or the cells remain normal, because if not, then we can pick up a precancer and treat it if there is a precancer or an abnormality, and then prevent cervical cancer. Because what we want to do is, with smears, Pap smears, and HPV testing, is prevent cervical cancer and obviously death and morbidity from that.
What is that test if they found something? What is that called again?
It's colposcopy. Yes. Yeah. So that's a sort of secondary test when they've picked up something abnormal on the smear. Not always. Sometimes it's a very mild abnormality or other not so high risk strand. We classify them in different risk groups, the HPV strands. But sometimes when we see, okay, there's a few things that we picked up, and gynaes are trained to know when we should look at the cells with the HPV or only HPV, certain HPVs, then you need to go for a secondary test, which is called a colposcopy. That's not a painful test. It's basically where a colpocyst, it's somebody that's trained to, I think that's the word, to work with a colposcope. It's like a microscope that basically zooms into the cervix. It's not painful, and you can put some fluid on the cervix and you can look and zoom in with a trained eye, or you get AI these days that also can help you, and that's also coming. But then looking at the cervix closer, and it's a little bit better than just looking at the cells on the Pap smear, because that's a sort of a blind thing. You just smear everywhere. But here, the colposcopy, you can look at where is there an abnormality. Is there an abnormality? Does it look precancerous like we see on the screening test? Yes, the patient. Where should I do biopsy biopsy if I think it looks abnormal. And then we do a biopsy sometimes at the same time. But a colposcopy is where we actually just, it feels like a pap smear, it's the same instrument that we insert, and then we just look with a colposcope closer at the cervix. Yes.
It's good to know that there are all these screenings to prevent and to sort of stop anything from developing further. It's just that people need to actually make a note of making sure that they go for all of these.
Yes, that's because cervical cancer is completely preventable with a vaccine or with secondary preventative measures, So it's so important that people just go for the screening.
Yes, and I think it's great that you actually mentioned there's a vaccine as well to help with that, because I don't know if people actually know that.
Yeah, I think a lot of people are scared. I don't know, after COVID, people are a bit more scared and what we call vaccine reluctant. But this vaccine is completely safe. There's no negative effects, it doesn't cause infertility or so, but yes, the same as a normal vaccine. It can cause a lot of pain at the injection site, maybe a flu symptom for a day or so. But other than that, it doesn't cause any, infertility or immune diseases. There's absolutely no evidence, and it just prevents cervical cancer. The only downside is the cost. If you're not in the government's program and you're not between 9 and 10 years old and you're in public schools, they give it for free. Otherwise, unfortunately, you have to pay for it. But it prevents cervical cancer, and it's so important that we try and get as many people vaccinated as possible, even if they've had sexual intercourse before.
Yes. Okay, great. Okay, so the next question. A lot of South African women, especially certain demographics, seem to suffer from hereditary hypertension. Can we unpack this a bit and maybe look at some holistic lifestyle changes that can help to manage this condition?
Sure. So I think it's very important to know your family history and to know your own medical history and to go for the checkups. Just as with the cervical pap smears, you need to go and check your blood pressure, And if you know that you have familial, hypertension or hereditary hypertension, it's important to note that you have to start screening early on. So go for that blood pressure check, even in your 20s, start early. And then there are many things that you can do to prevent it, or if you've now unfortunately already have the condition, to address it and even try and improve or reverse the condition. So it always starts with lifestyle, the diet that you're eating, a low salt diet, and they also call it a DASH diet, where you trying, it's a healthy diet for people suffering from hypertension. Physical activity is extremely important. It actually does improve your blood pressure control. Not drinking too much alcohol is extremely important. It plays a big role in hypertension. Not smoking, maintaining a normal weight. All of these lifestyle things are very, very important. So even if you have familial, let's say, predisposition to have hypertension, you can still manage your risk with addressing all of these things, and then later on, of course, going for medical checkups and treating it with medicines if it's indicated.
I actually read such an interesting stat the other day that only 20% of a disease or something, 80% is within your control and 20% is a hereditary passed on thing, but you can actually, 80% is up to you. You can change it through lifestyle.
Yes. Definitely. Your lifestyle can change your genetics, your epigenetics, we call it. And you can literally prevent hypertension by living a healthier lifestyle. You can prevent cancer by doing that. People don't think, they always think, we must treat the condition once it's there, but you actually need to do it, prevention is better than cure. So do it as early on as possible, because it does improve the risk or decreases the risk for hypertension if you do all of these things really correctly and help, follow a healthy lifestyle.
And then something totally off the topic, menstruation cramps, which all of us, most of us suffer from. You speak a lot about easing this, and there were some really interesting ones on your list actually that I hadn't heard of before. So what are your top 5 that you would use, and maybe just mention a few ones that aren't commonly known or used?
Okay, so, the first thing is that I want to say before I touch on, small tips, is that if you're suffering from severe menstruation pain or cramping, or what we call dysmenorrhea, it's really not something that you should suffer from, that so much so that it affects your quality of life. So you can't work or you can't go to school or university or whatever. You really need to then go look for a little bit more help than just trying small tips, because a lot of girls and young women and even older women suffer through it, and they just, they just feel like it's how it should be, but it doesn't have to be that severe. Yes, the first day of your period is a little bit uncomfortable. That's usually normal, and if you can control it with a Nurofen or a warm water pack, okay, and you can still go to work and you can manage and you can work through it, then that's sort of okay. But as soon as that it becomes more severe than that, you have to walk around with a warm water bottle the whole week, the whole month, because you've got so much pelvic pain, or you're literally missing school all the time or work all the time, then that's not normal. Then it's something that we should try and address medically as well. So tips would be, that's my first tip, I think, a very important tip, and the most important tip of all. You can manage it by yourself, that's fine, but you really need to try and go for a medical opinion as well if it affects your life. So go for a medical opinion if it's very severe and affecting your quality of life. There are small tips that you can do at home. People love the warm water bottle. Some people even like to put something cold that actually also helps with, like a cold ice pack on their bowels, although it's sort of counterintuitive to do that, but that actually also can help. Taking a warm bath, people like to do that. And then some foods, anti-inflammatory foods, I say, can sometimes help. I am of the opinion magnesium rich foods like chocolate and nuts and stuff, that some people feel relief and that can help them. And why not eat the chocolate if you're on your period? It's
Exactly.
fine. Yes, yeah. So small tips. I mean, I don't know if I'm at 5 yet, but I would say that's the tip. Go for a walk. It is good to try and be active instead of just lying down, because it really is. So that would be my but my main tip is go for medical opinion if it's very severe.
Okay, perfect. Great. So the next question actually sort of jumps onto that whole thing. I had endometriosis when I was in my 20s. Actually, after I had my child, it kind of went away naturally, which was amazing. But I couldn't go to work. I was one of those people that I'd faint, or the nausea and the pain was, I just spent the whole day crying. It was terrible. And it's such a relief to see that there seems to be some progression in this arena, because I mean, I'm in my 40s now, but at the time, I was sent to doctor and then specialists. There were certain things, but a lot of them, it kind of felt like it was dismissed, like I was maybe dramatic, or it wasn't as bad as I was saying, and that kind of thing, which makes you clam. You don't want to tell anyone then, because you feel embarrassed or you feel like you're not being believed and all of that. But it feels like the things are changing, which is fantastic.
Yeah, I think it depends on where you are. So notoriously, endometriosis takes very long to get diagnosed. And I think last time I read the stats or something like it takes 7 to 10 years to get diagnosed with endometriosis. That's a very, very long time, and we're still there, right? Certain people, if they go to the right person and they're lucky and that person is in tune for endometriosis, it gets picked up quickly. So thank goodness. But it's still something that we need to be more aware of, and healthcare workers need to be more aware of, and not just brush it off, or be like, judge people and saying, oh, it's just bad period pain. You really need to investigate why this is. And there's a cluster of symptoms that we usually look at, and obviously signs when we examine someone, and investigations that we can do. If the period pain or the pelvic pain is not going away with basic medical management or your basic Nurofen or even a contraceptive, then really you need to seek a second opinion, because maybe you have endometriosis, especially if there's lots of pain during your period, after your period, like you said now. So at least, so to increase the diagnosis is very important. So awareness and knowing the symptoms is very important. And then the appropriate treatment for endometriosis is also very important. So if you do have endometriosis, it's important to go to the correct, a gynae that also knows. Most gynaes are trained in endometriosis, but not everyone focuses on that. And not everyone is trained surgically to manage endometriosis. So you need to go to the correct person. And the management is also often multidisciplinary. So you need to get psychological support because this pain is a chronic pain syndrome that you're suffering with, so psychologically you need support. Dietitians can help with also an anti-inflammatory diet. Fertility specialists, because you might run into fertility issues and you want to prevent any issues there or address them. So that they definitely have a big role in endometriosis management. A pain specialist also, there's different pain things that you can do than just drinking some tablets. So I think, yes, we've come far, but there are still many women suffering from undiagnosed endometriosis where it's taking them years to be referred.
And also to check, the other thing that I think has a huge impact on that is also your hormones, because through those tests and everything, it only came out that I also had wonderful hormone imbalances, just to add to the whole situation. So that also has a huge part to play in all of that sort of situation.
Get a good checkup, thorough checkup, and if you want to know if your ovaries are still functioning, because it can influence we call it the ovarian reserve, the amount of functional ovarian tissue. There's a blood test for that we can do in endometriosis to see if you, and especially if you want to fall pregnant, to see if it's not caused damage on your ovaries, because it can, and tubes. And so the correct management is very important, and chronic management actually also. It's not something that you treat one cycle and it's just gone away. It's something that needs chronic management and follow up. So you need to make sure that you have the right person or the right healthcare worker or doctor or specialist that can help you with that.
Absolutely. In your opinion, how does overall wellness impact on dread diseases in women? How are the two linked?
So, personally, I believe the body and the soul is connected 100%. If your soul is unhappy and your mind is unhappy, it can definitely influence your physical health. We see that all the time. Even as doctors that are scientists, we see that. And so your general health is something that is so important. The exercise, the diet, I always say this, the basics, that people sort of neglect when they get busy. And then they have to manage a disease like hypertension that they get, but it's because they have such a stressful lifestyle. But they could have prevented it, or they can address it now, and then they have to manage this hypertension. But if their lifestyle and their overall wellness was better, they could have potentially prevented it, or they can manage it better, their condition that they get. So cancer is definitely linked to stress. Obviously, we know to smoking, just to overall being unhealthy. You have increased risk for cancers, for cardiovascular disease, which is the leading killer. So it's very important that overall wellness, and that I mean by that saying that is lifestyle, diet, your mental health is very important to sort of maintain your overall well-being.
Yes, absolutely. And also you touched on this earlier, movement, exercise and dread disease. It's the one thing that has a very strong tie.
And I always say, people think they need to go and run marathons. You really don't have to. We are more sedentary than ever since, our forefathers have ever been. We sit in chairs, we watch TV, we sit behind a computer working the whole day. We don't walk. We don't even walk to buy food anymore. We go through the drive-through, so that it definitely influences your well-being. So just getting your steps in, and I know people know this, but it is the basics. If you get the basics right, get your 10,000 steps in a day, try and move. If you like running, you can do that, but you don't have to run. That doesn't mean, you can find something that you enjoy while being active. You don't have to exhaust yourself and go and run a marathon, but you need to be physically moving.
You don't have to be an athlete. No one's saying
that. No. Just walking is extremely good. And stretching even, they've seen people that live up to 100, they're very flexible and they walk a lot. Resistance training is also very, very important. But that doesn't mean you have to go to the gym. You can do body weight training, you can do Pilates, you can do something like that. Your own home workout, 30 minutes, 3 times a week, that's all that you need. And then walking, really, it's actually not that much if you really prioritize it.
I mean, human beings used to have to go for days trying to forage for berries, find an animal.
Yes.
Exactly. And now all of that is
now we're not doing that at all. Exactly.
So that goes on to
diabetes.
Exactly. That links to our next question so nicely. Obesity and weight is often taboo to talk about. Once again, it affects so many women in our beautiful nation, and this often leads to secondary risks with various types of cancers. Can we unpack this a bit and maybe chat about a few ways to manage and prevent this?
Yes. So in my field with reproductive or gynecological cancers, obesity and being overweight significantly increases your risk for endometrial, so the inside lining of your uterus, for cancer there, significantly, and other cancers, we know that. It's also important to know that it very significantly influences your cardiovascular disease risk and your mortality risk of dying earlier on, especially. So in our Rainbow Nation, unfortunately in South Africa, about 40% of women in South Africa are obese, and that's a BMI of above 40. BMI has its downfall. You can be healthy metabolically and still have a high BMI, but that is something that you can see. Somebody just has a lot of muscle mass and they're actually very healthy. But somebody that looks overweight and their BMI is high, it is probably high, and that is an indicator that you've got an increased risk for cancers, multiple cancers, not only endometrial cancer, colon cancer, and then the other cancers, and then the cardiovascular diseases, and dying from that is the number one killer. So my tips, once again, is lifestyle. If you are already suffering from being overweight or being obese, it's something that is a long-term thing. It's a chronic condition. It's not something that, you're just going to lose the weight and then that's that and you're done with that for the rest of your life. It's actually a disease, and it's a very complex disease. It's not as easy as just stop eating, because that's also not healthy. So once again, if you want to manage it, you have to be in a calorie deficit, but healthily so, controlled way. And you shouldn't starve yourself. You shouldn't lose all your muscle while you're in a calorie deficit if you want to address it. The types of foods that you're eating, it's not only about a calorie deficit. Usually people used to think, okay, I can eat what I want, but as long as I'm in a calorie deficit. But that's also not good, because that makes you more hungry. So you have to eat healthy foods, low GI foods, for the rest of your health, for your gut health, for your microbiome. That affects your mental health. If your gut health is good, we also see that now in research coming up a lot. Activity levels we've spoken about, extremely important to address obesity. You can be in a calorie deficit. It will just be much easier if you walk your 10,000 steps a day. And then the behavioral things is also something that we need to talk about. How did we get here where you are obese? Is there something underlying, psychologically, that is affected you when you were younger? Or is there an eating disorder, maybe something that you really need to address? Because if we don't get to the root cause of the problem, that's not always a problem. Sometimes it's just an accumulation of years of struggling with weight, but there can be an underlying problem, behavioral thing that's the root cause of this that should be addressed. And then, of course, to manage obesity, we do get the medical things, the GLP-1s, the Ozempic and the Saxenda that is on everybody's lips these days. And it has its place. I mean, some people just resort to that straight away, and that's not what you should do. Lifestyle is what you should do. Because if you stop those meds, you can just pick the weight back up. It can help you a lot initially to lose weight, and it helps with diabetes control, and it has its place. But you cannot only rely on that. It's
being used cosmetically, and that's where the problem is. It's not being used correctly.
I think so. It's been abused almost in that sense, yes. And where it should be used in the right place, in the right setting, when all the other basic stuff are there and your lifestyle is, sorted out. Of course, then later on, if obesity really becomes a problem, we also, there is a place for bariatric surgery and all of that. But once again, people that perform these surgeries and are involved in this, they always go back to lifestyle. That must be in order first.
Of course, because if you're not making a mental change, it's not going to follow through. You're going to end up repeating the cycle and the habits that brought you to this place.
Exactly. And it's very difficult. People, some people would just tell somebody that's overweight or obese, but just stop eating it or just eat less. But it's not that easy. They're already usually eating less, but metabolically for them, it's very difficult. It's very complex. It's not just as, stop eating. It's a whole, a massive thing that we have to look at as I went through everything now to address small changes and permanent changes. Holistic thing. It's a
holistic thing. And I think also with these weight loss Ozempic and that, with these people that are using them cosmetically, I don't think they realize the damage that they're doing.
Yes, because
Anyway,
it's
that's
not
a
good.
whole other
Yeah, it's a whole other
thing.
discussion. It's not a side effect. It's not good to lose all your muscle mass, or to not eat anything. It's also not good for your metabolic health and your long-term bone health. And, it's also not good. So, yes, I agree with
No,
you.
your bones.
But it's something difficult that we have to try and manage, because it does really affect your life and your quality of life. Yes, everyone's going to die. Or some people say that to me. That I say, yeah, but you want to die 30 years earlier, not see your grandchildren or your children get married, or you want to be in a wheelchair for the rest of your life. That's also not fun. So it's about quality of life. And that's why we need to address obesity. Because the quality of life it's influenced very much with obesity and being overweight.
That's so true. Okay, the next question is very different. We're going to chat about sleeping. This is a lovely subject when you're in your 40s. I've found that as I'm getting older, my sleep cycles are very much affected. And I saw that you spoke about how hormones affect that function, and I didn't even realize how the two are so linked. So obviously perimenopause and high stress are contributors, but what else hormonally? How does that all work?
So sleep is also a very complex topic.
Yeah.
And you get sleep experts
Especially
that
with
literally.
women.
Yes, yeah. With the fluctuating hormones, it's not like our hormones are like this, and
Yes.
the female hormones are in a straight line. No, in the month, not at all. So sleep is so multifactorial. There's so many things that can influence sleep, from lifestyle, once again, to your screen time, to your stress levels, if you have anxiety or depression, and then your hormones physically in your body. Is your thyroid okay? That can, there are medical things that can also influence your sleep significantly. So specifically in females around the perimenopause, and
Yes.
definitely in the menopausal years. I mean, menopause, I read the other day again, I think that menopause can cause up to like 75 symptoms. Bizarre. It's like, and people underestimate the amount of symptoms and that you can get. And insomnia is definitely one of them. Women struggle to sleep as soon as the hormones start dipping, especially estrogen and progesterone start dipping in your perimenopause and in your menopausal years, and it really affects you. And then it's a vicious cycle of not sleeping, being tired, and maybe sleeping during the day, or it affects your mood. Now you're also more depressed. Now you sleep even worse, and it's just a
So
vicious
your
cycle.
whole cycle.
Many factors that goes into that. So there are many ways of addressing sleep issues. It starts with the basics. Try and get your steps in. If you're actually tired from exercising, you will sleep better. If you eat better, you will sleep better. If you don't eat high GI foods that give you these sugar spikes, you will sleep better. If you alcohol definitely influences sleep. And then screen time, lying in bed with your phone, definitely that will influence. So if you do these little, what we call sleep hygiene things, it can influence that. But hormones is something that, medical specialists can help you with. If you are perimenopause and you're really struggling to sleep, there is a place for giving you, let's say, a progesterone that will help you to sleep better. It does. It's sort of a side effect of it, and we use it together with an estrogen. If it's indicated and if it's safe for you, we can use hormonal replacement to definitely help with sleep. Women that have hot flushes don't sleep well because they wake up at night all the time from the hot flush, and then that's the reason for the insomnia. Sweating or being uncomfortable, or the joint pain that they get. So it depends on what the symptoms are, but there's definitely help. And just grabbing the sleeping tablet is not always the best thing to do, because they are habit forming and they're addictive. They have their place, but you need to be careful just to grab to that. You need to look at everything else once again. And then hormones, rather address the hormone balances of perimenopause and menopause. And there are other things that we can use, like melatonin, which is not addictive, which can also help if you're really struggling with that. And there are sleep experts. At my hospital, we have a sleep laboratory that you can come and see, and they can see what's wrong with your sleep, what's going on, how is your sleep cycle. You can use your watch. You can also, these days we have that to help us. So there are many things we should do before we just grab a sleeping tablet, because I'm a bit careful of them.
Perfect. Then we jump into a completely different topic. In your opinion, what are the best ways to prevent STIs, and what are your thoughts on the best contraceptives out there? Because I do see that, as you go through different cycles of life, your contraceptive needs change as well.
Yes, 100%. It doesn't
Exactly.
stay the same throughout.
No.
So let's start how to prevent STIs. Sure, that's a very loaded question. Basically, know who you're sleeping with. If you don't, you never know if you're going to get an STI. You can't believe somebody if they say to you, no, I'm clean. How do you know? You'll never know. And they might not have symptoms, as we said in the beginning of this recording, HPV, and they might give you HPV. And you might not clear it,
Exactly.
you might get something else, you don't know. So that's important. Condoms definitely help to prevent STIs, definitely, but they don't prevent all STIs, and HPV can still be transmitted even if you've used condoms, because just the outside area, the vulva area, can also HPV, and that can be touched by the other genital area, whatever it might be. Even though there's a condom on the penis, you can still get HPV from the surrounding area. So you need to be very careful with that. So I think, and go for the test. Let your partner test. If you have a new partner, it must be a trust thing. Let's go check ourselves out if we've had other partners before. Sexual partners, let's go do the STI screen, then we know we're HIV negative, we know all the other screens are negative. It's a simple urine test that you can do. You can ask for it at your GP and they can give you a form, and both of you go and you go for a pap smear, and that's done. So that would be my tip with STIs. And then the best contraceptives, I can't choose one because there are so many, and there's so many different methods contraception, and it's so personal. It depends on what age you are.
It is so personal.
Your fertility, how you react to hormones, what underlying medical conditions you have, what gynecological conditions you have. Do you have PCOS? Do you have endometriosis? So there's so many things. Hormonal contraceptives have a lot of advantages. A lot of people are scared of them, that they're going to cause infertility if they use it for a long time. And that's very controversial and not really proven, but they definitely have a benefit at a place, And there are different methods. There's even natural methods that are less reliable than the meds for IUD, but some people rely on that, and if that's their choice, then that's their choice. So I can't really choose one above the other. I use different types. I do like a Mirena IUD. I wouldn't say that's my best one, but it has many advantages, but it doesn't work for everyone, so it depends on a case-to-case basis.
It is good to know, though, that there are lots of different options available, and to explore them properly.
Yes. And we do get non-hormonal ones, like the copper IUD, although it has different side effects that you might not like, a heavier period, more cramping. But there is, that option if you really don't want hormones. There are other options. And I usually go through a whole list and a whole picture with my patients when we're deciding together on what to use, because everyone is different, and what might be appropriate for you might not be for the next person.
Absolutely. I'm going to quickly jump ahead because the one question I was going to ask you is extremely long, possibly the answer. So you're definitely a believer in self-care. Can you chat to us more how you fit these into your busy schedule, and what are some of your favorite ways to include that in your life?
Yes, I'm definitely a believer in self-care. I have to prioritize it. I think everyone has to prioritize it. So if you don't make it a time in your schedule to say, this is my gym time or this is my running time, you won't get to it, and you'll feel guilty if it's not a fixed thing every week on a Friday morning at 7, this is my time to gym, and everyone in the household knows, that this is my time. If you don't do that, then you'll start exercising and doing self-care less and less and less. So I try and prioritize, basic stuff, my own hygiene, my hair care, my skin care, and also my physical activity, my diet. I'm not perfect. I go through the times where I don't get to it, and I'm like, okay, let me reschedule that, bring that back into my schedule, because it is a busy schedule. But you have more time than you think if you really prioritize your day correctly.
And turn it into a routine.
Yes, so it must be like, that's what I mean. So I've got a 3-year-old daughter, which makes it very difficult. I've got also traveling with work, but we make time. He likes exercising, he prioritizes it, and I must say, I take that from him. He has actually helped me in that sense, where it's a priority for him. And we make it a part of our lifestyle on a weekend, especially. We go and walk with our daughter. We try and in the summer run with her, in the pram, whatever we can do. There are different ways. It's never going to be perfect. We might miss a session here or there, but to get it into your routine and to say in your mind also, because you're not always going to feel up to exercising. Let's say now exercising. But if you know that on a Friday afternoon at 4 o'clock, this is the time that I go for my walk, then it's sort of in your brain. You just automatically do it if it's part of your routine. And that's how I try to do that. Yes. Yeah.
Perfect. And the last question, what are your thoughts on the connection between regular movement and female health?
So my thoughts on the connection between that, and I think we've touched on this already, but it's extremely important that you move regularly. We've talked about this, I think, but it's directly linked to female health. Health is defined in different ways. Your mental health, yes, it will definitely help your mental health. Spiritually, it can help you. And then physically, medically, it prevents cancers, it prevents chronic cardiovascular disease. It can help with pain management of periods. And if everything is in balance, then your cycles might be more regular. And if you walk more and you lose a little bit of weight, your PCOS might be better. It definitely plays a massive role, and there's a massive connection between movement and female health. It's extremely important to be active on a daily basis if you can, or if every other day, but to prioritize it, because it makes such a difference. I can see the difference in my patients, the ones that are moving. However, you don't have to run a marathon once again. The ones that are just moving in whatever way they want versus the ones that are not. They just feel better. They just mentally better. They are just healthier.
Fantastic. I just want to mention that there's a whole fertility conversation that we've run out of time to have. But to the people that are going to watch this, I just want them to know that you deal a lot with fertility assessments. And so to them, and for anyone else that has watched this and feels like they need to come and see you, how can people get hold of you? How can they contact you?
Yeah, so on the fertility note, before I give you my contact details, I'm not a fertility subspecialist, but I am a gynecologist, and I do the initial, chat assessments, and I can definitely start getting assessments and the basic management of infertility. I definitely do, but I do refer if it's very technical, and I don't do IVF, for instance. That's not my field, but I know where to refer you and what your preferences. I'll speak to you about preferences if you're a patient, and we can get the right fit for you for fertility. But I definitely want to advise people that have been struggling to fall pregnant. It might be triggering, but if you've been trying for 6 months and nothing's happened, really you've been trying, and you're above 35, rather go for the help sooner than later, and ask. Even if it's me or your GP, just start asking the questions and getting the assessments done. I think that's very important. But for anything that we've discussed, if anyone wants to come and see me, or they want to talk about their cancer risk, or they want to exclude cancer risk, or I work with BRCA patients that have the gene, the breast cancer gene, but also increase your risk for ovarian cancer. So if you know that you want, or you just want to check up, or you just want to chat about your periods or your menopause, I do all of that. So people are welcome to contact my rooms. I've got an online website, so you can just Google Dr. Celeste van Drunick. Maybe you can put up a link or something, or you'll tag me, hopefully, because the spelling might be a little bit difficult. I'm on my Instagram, so at Dr. Celeste van Drunick. And then my reception has an email address, or the number is 021 506 5175. If you just want to have a phone call, just chat to me or my receptionist. That's also fine. I do telephonic consults if I need to. So I'd love to chat to anyone that's interested or needs help.
Okay, perfect. Thank you so much for joining us today. It's been an absolute pleasure. And I hope that we can have another full-on conversation in the near future about all the things we didn't touch on.
Thank you so much for the opportunity. I really appreciate it. I had a lot of fun chatting to you.
Thanks so much.